show the wrong screen. So I want to make sure. All right, good morning, everyone. My name is Bri, or Brianna, if I'm dressed up and looking fancy. What do I do? I'm a pediatric emergency medicine physician. That is what I trained to do. I went to pediatric residency down at Harbor UCLA, where Chip is, and I did fellowship there as well in pediatric emergency medicine. All of that with very limited mental health training, I would say, because we are lucky to have a mental health ED at Harbor. And so I came to children's without a lot of that experience, and now have been thrown in here. In addition, I've taken on the role somehow, as a lot of other people on this call can vouch for, of being in charge of disaster for the hospital, because that usually falls to ED people. And they just say, hey, you might be interested in disaster. Why don't you try to get involved in this and see what you can do? And you find out that you're going to build an entire disaster program. So that's what we've been doing. So I come at this with two lenses, I guess. Actually, probably more than that, because I'm also a parent who has sought mental health care for my child. So maybe multiple lenses, just from an ED perspective and from that kind of larger regional disaster perspective as well, as we try to deal with many, many things at once. So I'm going to try in this brief 30 minutes to discuss kind of what this has looked like in one ED. I'm going to give you an example of our emergency department, which is lucky enough to be a children's hospital. We should have all the resources anybody could ever want to care for children. We are blessed with a very established mental health care program. And you can see what happened to us over the last few years as kind of an example of what can happen when something is hitting a crisis at the same time that other things are hitting crisis. We'll look a bit on what that does to your capacity and your care for those, not only those patients who are seeking mental health care, but really your patients who are seeking you in a moment of medical crisis as well. We'll talk a little bit about emergency department staff and those impacts, and then what we try to do to kind of turn the tide. I also am on the HRSA grant for the PPN, which I am very happy to be involved in. That's my only disclosure. So when I started at Seattle Children's, I came to an emergency department that had TVs like in every room and video. It was a very different environment than what I had trained in, but it was tiny. It was this little ED that you see here on your screen. That was the entrance. You can tell how dated this is by the van out front. And it was a 14-bed ED. I think one of the rooms, I don't even know if it was truly 14, because I think nobody has a room 13. One of the rooms had 4 beds in it. It was tiny. And we were lucky enough, I think at the time, to have 2 social workers, not just one, but 2, who could help us when a patient came in with a mental health or behavioral health issue. These 2 individuals were godsends. I know their names to this day, even though they have left me long ago. And they were the people that we waited for, right? So if a person came in with a complaint of suicidality, we would manage them medically, of course. But then, honestly, they would wait until the social worker had a shift that day, and hopefully they could help us maneuver through this complex mental health system that existed at the time, and probably is more complex now. In that ED, we had one kind of what we called the safer room, which was, now I look back and think it wasn't a very safe room, because we've developed some safer rooms since then. But that was what our ED was. That was what our team was. It was 2 social workers that we hoped would be on when we needed them. And, you know, an ED attending like me and a nurse. We usually had one ED attending on at night. I don't have data. I was trying to get data from the earlier times. It was hard to get. But at that time, back in 2006, we were seeing, you know, 1 patient a day, perhaps, maybe one every other day. That was 2006. By 2011, we knew that we're seeing more and more patients. So I think this is just, you know, one example of the slice of the pie that is the mental health crisis. And we knew that something was happening. We had still our safe room, but we started to look at what more could we do. And so this was our first kind of attempt to get the hospital to understand kind of that the ED was becoming an increasing resource for the community, where people were falling through the gaps and where they needed more assistance. So they were showing up at our door, and we didn't really have the capacity, we didn't have the tools, we didn't have the resources to help them, and we needed more help from the hospital. It took a lot of advocating from our leadership, but in 2012 was really our first major ED mental health model of care event. And this was one of our clinical directors saw this through. He obviously saw something coming that a lot of people didn't see, and he kind of directed the eyes of our hospital administration to look at this as a coming tide and something that we needed more assistance with. To this day, I'm thankful for that event, of course. So this was also, because he was smart, he's one of the smartest people I know, at a time when we were talking about building a new emergency department. So our tiny little afterthought of an emergency department would be getting shined up, and we might have the opportunity to build a new emergency department. And so this work actually would be a foundation for what we would do in the new emergency department to make us kind of hopefully the model for mental health care if you're coming to the emergency department. That was what we thought, of course, and for all care. This was what we got. We got this beautiful building. We didn't get the whole building, of course, don't get me wrong, but we got this beautiful building. We got an upgrade. You can see the cars are a little more recent, but we had the whole first floor of the emergency department. And we thought we were so smart because we built it with 4 safer rooms. We thought, you know, we should build extra because we're building for the future. We should have 4 safer rooms to make sure that we can keep kids safe while we're seeing them and providing them care in the emergency department and getting them to their next destination for care. So that was our big idea. And this is what it looked like this is huge. Our old emergency department fit into kind of this little area on the left. Our new emergency department was the length of a football field. All these rooms in yellow were patient rooms. So this was a monstrous emergency department. We thought that this was going to last us for years and years to come. We actually had the audacity at one point to think we didn't need a lobby. We actually discussed, would we be so good at getting patients back that we don't even need a lobby? But we built one, thank God. And we had a Starbucks in that lobby even. It was the only 24/7 Starbucks that existed. We had, you know, a lot of other spaces that look like open spaces, which again, you'll see what happened in those spaces. But we've gone from our tiny 14-bed rooms to 38 treatment rooms. 26 of those were typical. 4 of those were our calming rooms. We had them located kind of off in corners of the emergency department, or where we had people who could watch them and hopefully away from exits. And then we had our treatment rooms and our trauma rooms, of course. And then in the middle, we had this big ED space because that is how we wanted to design this, so that people could find us. When you're designing an emergency department, you think you're designing an emergency department for a few hours of a stay. You think that people are going to be there for hopefully a max of 4 to 5 hours, maybe longer if you're a little bit more complex. And so you build it in a way that makes it safe. You build it with open windows for doors, right? Because you want to be able to see patients. You want patients to be able to see you. You build it with big open spaces, and you make it beautiful and calming. That was a big thing. It had to be beautiful and calming. That was one of our big goals. And I thought this is a very empty version of it because this is like the design stage, but that was what we accomplished, we thought. Because this is what you usually do in the ED. You see patients for about 4 hours, sometimes longer, but this is for admitted stage patients, this is kind of where we hang out as far as time spent in an emergency department. Because really you don't want to spend longer. I think probably everyone on here has been in an emergency department. Nobody wants to be in an emergency department longer than a few hours. And so that's how it's designed. It's not the most comfortable room. They're small. Most of them don't have windows, especially if it's a calming room. And they're really made to kind of like burn and turn. That is what you're trying to do, is get people into their next space, get what they need in that time. So as the ED opened in 2014, it was already happening. So you could see the rise already starting. So we still thought we were going to be okay. We had our 4 safe rooms, right? So we've got that going for us. But as you all know, this is what happened. So these are our raw numbers of just census for the next few years, including this year, which of course hasn't finished yet. Obviously, we were not ready for what was coming. We, of course, didn't anticipate a pandemic, but all of those things are what the ED was facing. And here's a piece of the puzzle, and I think that Kate and Mo touched on this a bit, but here's one piece. It's that there's this length of stay that happens with patients who come in for behavioral health, because these aren't quick visits. These are visits that require time with families, they require time with the patient, they require time coordinating efforts to get them follow-up if they're actually going to be able to go home. And so these are visits that just take longer, and you could see the times increasing. This goes up to 2022. I just looked at our data. It gets a little confusing because we changed some definitions, but our current times are always in the 30-hour marks for averages, often in the 40-hour marks for these busier days. But that doesn't include really what we're really seeing, which is this acuity that's increased to the point that we can't send people home. So this idea of finding kids who, aren't currently suicidal and didn't currently try to hurt themselves or weren't so aggressive that their family has no idea what to do with them anymore. Those patients don't exist anymore. That's not what we see anymore. What we see now are parents at their last, they're at their last bit of energy to deal with a kid who is just out of control and aggressive and threatening their other children or hurting themselves or hurting these families. They are kids who have been in and out of our ED so many times, there's no way we can send them home again. This is what we're facing. So it's not just raw numbers, it's kids who have nowhere to go. And that's the thing. When you try to sort this out, and we've tried continuously to try to figure out how do you tell this story, because the only way we're going to get the help we need in the community and even within our own other community areas is by telling the story over and over. So that's what we do. We just tell the story as many times as we can to make sure that people can understand what the impact is. And we try. This is kind of a look at, maybe we look at length of stay hours as a percentage of total hours in the ED, and you can see those are going up as well. But it doesn't really still tell the story. So we end up coming back to the only way to tell the story is to tell you literally what is happening for the people and the patients who are there every day. So here's an attempt at that. This is our ED lobby as designed. God, it's so pretty. This is what we designed in the ED. It comes in, it's all welcoming. Look, there's like natural wood tones. What could be more calm than this? There was this beautiful garden at one point, all kinds of things, nice and spaced out. Obviously, this was a nice day with all these staged people. The problem is, this is what our lobby looks like now. So this is a busy night in our emergency department, and it's not an uncommon night in our emergency department. And this is what I can tell you, that most of the people who do emergency medicine or work anywhere near an emergency department are probably shaking their heads right now, agreeing with me. This is what your waiting rooms look like now. This is not pretty. There's no way this is COVID safe. This is the reality of what is happening. And it is when you take away a huge amount of capacity to see patients and you're experiencing surges like we've been experiencing, you can't get to all the patients. So, I mean, trying to sort this lobby is an impossible task, I would say. And find the sick kid in there, right? This would be like a Where's Waldo of the worst case scenarios, right? Find the sick kid. So this literally is the Tetris that we do in that huge ED that you remember we built. This was Monday. So I worked Sunday and I worked Tuesday. So I wanted to catch you some real data, but I watched Monday while I was just kind of hanging out doing other stuff. And this is Monday at noon. So this is 12:30 in the afternoon on a Monday. We should not be that busy yet, because we always know Monday afternoons and evenings are going to be crazy. And already in those ring of beds, remember these are the beds around here, everything with a yellow symbol next to it is a border. That is a psych border in our emergency department Monday morning at noon, before the surge is going to hit. This is what it looked like. In addition, this Monday, as I was watching, there were actually 3 more patients being evaluated. So those are 3 more of our beds that were being used purely for mental health reasons. That's 17 of our 44 rooms. That's 38% of our physical emergency department capacity. So you've just taken our emergency down by 38% to try to see whatever surge is about to come into the emergency department. And this is when it becomes an undoable task and the Tetris begins. I also forgot to mention, we also had 6 patients at this time in a satellite ED area that's still called the ED, even though it's a building away and five floors away. We had 6 patients housing there who are getting care, but awaiting disposition. And so we're officially still counted as ED patients. Wrong way, sorry, hit the wrong arrow. We had 2 more patients in the lobby who were waiting to be seen. They'd already been there for an hour or 2, waiting for a safe room, because all of these rooms had been converted to safe rooms so that we could keep them safe in these rooms, hopefully. And these 2 patients, there weren't any rooms left to see them, so they were going to have to wait until we could find a space to see them in. They might get seen in one of our consult rooms, They might get seen, honestly, in a corner of the lobby if that's what was needed, and they were kind of on the lower acuity end of things. But this is what we were using. So what does that mean for everybody? That means that there's a probably suicidal or at least family coming in crisis with a patient, 2 of those waiting in the lobby. And there are a line of patients starting to form as I was taking these pictures. In the next hour, we actually got 20 patients arriving within the next hour. So we had 20 patients who needed the beds that are left here, which is really just a handful of beds to see those patients. And that was before school was even out that day. So that Starbucks lobby that we used to have, this is what it looks like now. This is our Starbucks lobby. No more Starbucks 24/7 for us and for the families. That is gone. We have a space essentially where we see people in these chairs, and this might be where you can come in and you might have acute appendicitis. And honestly, a good chunk of your stay might start here. We've taken care of cardiac transplant kids, just pull them into a space to get them started somewhere in spaces such as this. This used to be a supply closet. This is now there's actually another bed here. It's funny they took it out for this picture, but this is actually a 4-bed space to pull some patients in and see kind of low acuity fast track patients in our old storage room. This is an example of one of our worst versions of a waiting area. This is a lobby outside. Those are elevators. This is a floor above the emergency department. It is where you used to just go to administrative offices. So at least it's not near other patient care, but near administrative offices. And this is where we had to, on some nights in our worst moments, put patients just to give them somewhere to sleep while they were being evaluated, and someone could keep an eye on them and try to keep them safe. This is what healthcare looks like right now. So what have we done to kind of take care of these kids? We've done a lot. I have to say, when I went back and I reflected on what has changed, we have done a ton of things to try to make this tolerable and to provide care to these kids and still be a referral center for the sickest kids in the state and the region. So we've obviously increased staffing. I think every emergency department could say they've had to put resources into this. But what does that mean? We've increased staffing, right? So so remember we had those 2 social workers before. This is our staff taking care of patients in that snapshot I just showed you. And that was just for that time during that surge. In the evening time, I think we actually go up on staffing, believe it or not. But that is what is required currently to manage just the mental health patients that are classified as ED patients currently. We've obviously done a ton to try to initiate the care in the emergency department. We've used every tool we can find to kind of start these kids in their care. They're not just hopefully sitting around waiting to get to an inpatient setting. We're actually trying to take care of them while they're in the emergency department and using it as a satellite area to do mental health care, but obviously that's not ideal. We've expanded the ED shell space. So we built that ED with an area that in the future, it was supposed to be 10 to 15 years, we could build an additional 9 beds, I think it was. And now we have already built those beds, and those were the ones that were holding mental health patients recently and currently. We've gone through about probably 6 different satellite sites in the last 3 years where we have temporarily held patients who are still classified as ED patients but don't have a disposition yet, either waiting for discharge or waiting to be admitted. And so we have had to set up and establish kind of rules and protocols and policies for these different satellite sites. And currently that one we have is the one that I described a building away right now. And a big thing, I think, and this is kind of, I hope that people move towards this quite a bit, is that what we really recognized is the worst part of this, as far as care for these kids, is that the last person you want taking care of you after 4 hours is me. I will gladly explain that to you anytime, but I am dealing with a front door that is wide open, and there are all kinds of emergencies coming in. And I can tell you that we are running from place to place to put out fires. And so I am not on top of, did somebody talk to that parent today, since that kid's been here for 3 or 4 days? Did somebody, make sure that kid got a bath? Did somebody, we're not rounding like inpatient physicians. This is an emergency department setting. We're not built like that. Our environment's not built like that. We don't even have separate, they have to use these shared bathrooms. The other day, while I was managing a patient that needed to go stack to the operating room, and the only other attending in the space was managing a kid who was hypotensive and starting pressors to maintain their blood pressure, we had a kid run out of the ED and jump on a bus, who was one of our mental health patients, and had to get chased down. And there was no way I could even help the team figure out what to do next, because we were busy with these other high acuity patients. So one thing that has happened is that as patients have been being are kept longer in the emergency department, we have transferred care to the mental health team, and that has been a huge difference, I think, in the quality, at least, of the care that they're receiving, given the limitations of the space that we're dealing with. And that is something I can't emphasize enough, as far as the daily kind of check-ins and continuity of care that provides these patients is huge, and I think is essential, honestly, if you have patients supporting for a long period of time. And it took a lot of advocating on the part of our leadership. It took a lot of discussions, but we got to that place, and I do think that does improve the care of these patients. What that leaves us with is an ED full of people who are trying to do the right thing. We have people who are so committed to this work that they have devoted their life to taking care of kids, whether you're on the ED, you're an ED nurse, or you are one of our mental health care evaluators, or you are, one of the mental health psychiatrists on there. We are all in this game to make the care of kids better, and to give it the best care that we can possibly give, and we can't give it anymore. Like we are daily inundated with how short we fall in the care of these kids, and the problem is, it also impacts the care of all the kids coming to us. So I can't get to the kid who is, wheezing in the ED in the lobby. I'm going to go see them in the lobby because we don't have a room to see them in. So this is a huge impact to all the care of all of our kids, and most importantly, these kids who are coming to us in crisis, in mental health crisis, and being stuck in an emergency department. I don't even know what to say about moral distress, because you can't sum it up anymore. I think that I've never seen people at the stage that we're at right now. So I appreciate that you all are here to try to help find solutions and share solutions to how to care for these kids. I don't work with any nurses anymore that I know. If I see 2 or 3 nurses on a shift that I know, I'm excited. I hug them every time I see them. So hopefully they'll come back, because they don't come back. I've had nurses who I thought were going to be lifers with me and were part of my family for years, and they can't be in the ED anymore. And this is a big part of it. And yes, the pandemic was hard, but it wasn't that hard for peds, to be honest. This was hard. This is hard. This is what is making people either leave the emergency department, leave mental health, or leave just this profession, period. Our turnover in our ED last year was 13%. That was better than the 18% the year before. But it doesn't even, numbers and percentages don't tell you kind of the whole story. You generally get an email from a staff member who's leaving, who describes kind of how they can't come in anymore. They can't face this anymore. They can't do this anymore, when you know that you can't provide the care you need to give. I think you can provide resources, and we do. We provide resources, and we try to do staff assistance. But it's really, I was there 2 of the last 3 days, and I can tell you, I had I reflected on this, I would say more than 10 conversations one-on-one with people where they just needed to download kind of their distress and discuss it and just process this, because no one else understands this. If you're not in this environment, people don't understand what this is like. They don't understand what it's like to hear these kids moaning and yelling for their moms and chasing them up through the hallways to keep them safe. People don't get this except for the people who are doing the work. And this looks scary, this looks overwhelming, but this is our jam, right? Like, I can do this. A lobby full of sick kids, like, we can sort this, we can get through that. My team does that all the time. But this, we can't do this. Like, this isn't what we can handle. And so this is why I think that, you know, all I can say about this is that if you know people who are doing this work, which obviously most of you do since you're here, if you know parents who are experiencing going to the EDs, you know, talk to them and check in with them and see how you can help them to process this. But it's a hard thing to process. So it leaves us with a lot of tears and helplessness. So what do we do about it? You know, we're doing a lot of things as much as we can in our own institution, but the kids just keep coming. I can tell you that I don't even know the number this morning. I couldn't even look this morning, but I'm sure we are above 26 patients with mental health concerns in the emergency department. We have been pretty much every day this week. The problem now, of course, is that we're surging. We are seeing RSD and we're hitting our numbers. So we're going to have this lobby that's going to look like this. So all we could do during this time was to try to tell the story and try to get data so that we could get action where we can. So back during COVID, at the beginning of COVID, my God, this is way back. We didn't know what capacity was in our state. We had no clue other than my shift administrator literally calling each peds hospital to say, how many beds do you have left? It was insane. There was no way, you know, because our state tracking was a snapshot, but it wasn't always put in by the right person. Nobody had a real good gauge on what was going on. And so during our pediatric work group meetings, which we began meeting obviously more frequently during the pandemic, we just started writing it down. And all we did was put this in an Excel spreadsheet. Like, this was nothing fancy, nothing near what Chip has put together. This was an Excel spreadsheet that literally we put on a team site, and we said, like, let's just start looking at numbers so we can understand how bad things are getting. And we focused on what you think you'd focus on, right? We focused on how many critical care beds, how many acute care beds do we have left in the state? How many COVID kids do you have? We had ECMO at one point. And we just kind of went from there. And at one point, we just started to notice, you know, we're seeing more mental health patients and we're seeing more boarders. And nobody had any idea how many there were until we would start saying, you know, on these calls, I've got 5, I've got 6, I've got 8. And so until you started really talking to them, you didn't know if, is this just you or is this everyone? And you were kind of hearing anecdotally. So we literally just added a couple columns, and we started asking this question at our meetings. And we said, how many surge boarders do you have? And that's how we started collecting data to really understand kind of how big is this problem. And luckily we have an amazing healthcare response network, and they worked on this and they saw how valuable this was. And they worked very hard to get this data in. And now we have statewide data that comes to our inbox every single day. So every day, well, Monday through Friday, every Monday through Friday, I get a snapshot of how many boarders we have in the state by hospital, by region. And it's included on kind of if you're going to get one piece of paper or one screen, I guess, in front of people who make decisions about resources in the state, this is the sheet that we want for peds. It's about ICU bed availability, it's about ED visits for sure, but it's also about boarders. And we have psych boarders equally represented on this page. And this is what goes to across the state, Monday through Friday, so that we actually have this data and we can tell these stories to go with the data. And I think it's helped. We've had, you know, we give this to our legislative groups, we give this to our Department of Health, everybody advocating very hard. You know, we had our governor did declare this as a focus, this youth mental health crisis is a focus. We have some new legislation that's looking at kids who are stuck in hospitals where, you know, they don't meet medical criteria, but they're still stuck in the hospital. So this is how we feel like we can make a difference in this piece of it, is to kind of keep telling our story, keep collecting the data, and keep putting it in front of people so they can't pretend that it isn't there. And that hopefully will continue to make this world a better place for the kids that we all take care of. And I think I'm at time. I kept my time, Tona.